Okay, so I'm going to talk about racial disparities in hormone receptor positive breast cancer. Just an outline, I'm going to go through some racial differences in breast cancer incidence and subtype, which Eric pointed out, how breast cancer survival differs by subtype and how racial disparities play into that, and then focus on a couple of mechanisms that can contribute to disparate outcomes in ER-positive breast cancer. So just to set the stage, what are disparities? I'm an epidemiologist, and basically what we do is we look for differences, right? And some differences are things that we expect and are supposed to be there, but disparities are differences that shouldn't exist. So, let's look at the data for breast cancer. So when I used to do these talks a couple of years ago, I would start off with this conundrum that Black women had lower incidence rates of breast cancer as compared to white women in the United States, and yet had higher mortality. I can't say that anymore because as of data that came out last year from the American Cancer Society, incidence rates between Black and white women have converged. And as you can see here in the graph, so white women are in the green, Black women are in the blue. It's sort of a combination of decreasing incidence rates in white women and increasing incidence rates in Black women. And data for other groups, you can see we've only had it much less recently than Black and white women, but for Asian Pacific Islander, American Indian Alaska Native, and Hispanic women, incidence rates are much lower than we see in both Black and white women. If we shift over here to mortality, it's a completely different story. So let's start with what's good. You see that the slope on all of these lines are going down. So breast cancer mortality is decreasing. But this line in green, which is mortality rates for white women, is much steeper than we see in other groups. And so though everyone is declining, actually differences between Black and white women are widening. So Eric showed this earlier. It's important to note that breast cancer isn't just one thing. It's a disease that's made up of multiple subtypes. This is data from gene expression analyses. And often when we're doing epidemiological studies to try and understand both risk factors for breast cancer and survival from breast cancer, we don't have gene expression data. So we sort of approximate these subtypes by using markers that you may have heard of, like estrogen receptor, ER, progesterone receptor, PR, HER2, and then tumor grade or Ki67. Ki67 is a marker of tumor proliferation, so it's how fast is the tumor growing, and tumor grade is a measure of how well differentiated the tumor is when we look at it under a microscope. So that means how far away from what a normal cell looks like is this tumor cell. And so we can classify tumors into a bunch of different groups. ER-positive tumors are the luminal tumors, so they're luminal A and luminal B. They're ER-positive. What differentiates the luminal A and luminal B tumors is luminal A tumors are HER2 negative, and they are low Ki67, so low proliferation, or either low or intermediate grain. So these are the slowest growing of these different types of tumors. Luminal B tumors overexpress HER2, or they are high proliferation tumors as well. And then you have the ER negative subtypes, which includes HER2 enriched. These are ER, PR, HER2 positive. Or basal-like, which you may have heard of, which are ER-PR negative, HER2 negative, and then they also express two other markers, cytokeratin 5, 6, or EGFR. So basal-like includes the triple negative subtype, which you may have heard of. So the importance of subtypes is that they vary with respect to risk factors, sites of metastases, and also response to treatment. And so if we think of this in terms of race, let me just orient you to the data I'm showing you here. So there are 4 boxes here. They're showing you age-specific incidence rates from the California Cancer Registry by race and by subtype of breast cancer. So the top box up here is for white women, then black women, this is Hispanic women, and that's Asian women. And so, you know, one thing might strike you immediately, which is for white women, these rates of luminal tumors, which are in blue, are quite high. They're much higher than for any other group. And the other thing, which is, I think is a little harder to see, is that the rates of triple negative breast cancer, which is in red, are higher for black women than they are for any other group, and much lower rates for Hispanic and Asian women. So this is looking at incidence rates. If we look at among women who have been diagnosed with breast cancer, what is the distribution of these different subtypes? We see these differences reflected there as well. So just to orient you, this is showing you the percentage of the different types of tumors according to race, going from non-Hispanic white women, black women, Hispanic, and Asian or Pacific Islander women. And so we'll see that here, these are the luminal A tumors on the bottom. They are the most common type of tumor in every group. But you'll see that there are some differences in terms of the distribution, such that for non-Hispanic white and Asian or Pacific Islander women, you know, over 55% of the tumors are this slower growing type of tumor, as opposed to for black and Hispanic women, that percentage is lower. And for black women, the difference is really coming here, which is, it's quite different than other groups. So over 30% of the tumors in black women were this basal-like subtype. And they have a much lower percentage. Luminal B tumors are in yellow. They have a much lower percentage of luminal B tumors than any other group as well. So this is important because these subtypes are associated with outcomes, okay? So this is data showing you survival probability according to the type of tumor. And this line here on the bottom is triple negative tumor. So as these lines go down, that means that women are dying. So if everyone survived, we would have a straight line that goes across the top. And so you can see that this top, the very top line, which is women who are doing the best, are the luminal A tumors. And that bottom line, which is women who are dying, where, you know, a little over 75% of those women are still alive at the end of follow-up. Survival time here is the x-axis, so this is 5 years of follow-up. You'll see that the triple negative tumors did the worst. And this is data from Sweden. Sweden has an amazing national healthcare system and great cancer registry data, but you know, if we look in the United States, we see the same thing. This is, again, data from the California Cancer Registry. Purple is the triple negative tumors. Blue is the luminal A tumors. So again, triple negative, HER2 overexpressing, which is another ER negative subtype, is yellow. That's also doing worse than either the luminal A or luminal B tumors. So we were really interested in trying to understand how do these differences in the difference in distribution of subtype and the differences that we know in terms of how subtype is related to outcomes, how does that play into racial disparities in breast cancer survival? So really we were interested in, you know, to what extent is subtype driving disparities, and do we still observe disparities within subtypes? So we use data from the National Comprehensive Cancer Network, their breast cancer outcomes database. And this is a network of comprehensive cancer centers across the United States. Dana-Farber is one of them. And we included women that had stage 1 to 3 breast cancer that was diagnosed between 2000 and 2007. This included over 16,000 non-Hispanic white women, over 1,500 non-Hispanic black women. And here's just some of the characteristics of the women at baseline in our study. So, on average, we were able to follow up the women between 6 and 7 years. And we found that compared to whites in our study, Black women had younger age of diagnosis, higher BMI, more comorbid conditions. So comorbid conditions means that they also had hypertension or diabetes in addition to a breast cancer diagnosis. Were more likely to have Medicaid insurance, presented with tumors that had less favorable characteristics, but we saw no differences in receipt of therapy. So, whether you got chemotherapy, hormonal therapy, or targeted treatment for HER2 positive breast cancer didn't differ between the groups. And so when we looked within groups at survival according to subtype, here's data for whites and here's data for blacks. The different colors are the different subtypes. So black is luminal A, triple negative is like a blue purple color. We see that in both groups, luminal A tumors performed the best. So those women had the best observed survival, and in both groups, triple negative tumors had the worst outcomes. But when we compared survival between Black and white women, both overall and according to subtype, we saw some interesting findings. So just to orient you, here I'm showing you hazard ratios. So these are comparing the risk of death from breast cancer between Black and white women. This line here that's marked in red is 1, so anything that, if this bar crosses that, that means that those associations weren't significant, they weren't statistically significant. And then I'm showing you associations for all tumors, luminal A, and then triple negative on the far end. And so what we saw is that when we just adjust for age, we found that Black women were about twice as likely to die from breast cancer overall as compared to white women. When we looked at just luminal A tumors, that was 2.5 times more likely to die. And for triple negative tumors, it was about a 40% increased risk of death from breast cancer. And then when we adjusted for all the different things that we think could confound the association, so all those things I showed you in that first table that were different between Black and white women, we found a persistent 25% higher risk of breast cancer death among Black women, a 77% increased risk of death from luminal A breast cancer, but no difference between Black and white women for triple negative breast cancer. And so these findings that I just presented to you from our study have been seen in a bunch of other studies. Here I'm showing you estimates from the Carolina Breast Cancer Study, which is a large population-based case control study in North Carolina, Women's Care Study, and then a cohort that's in Chicago. And they all saw this consistent increased risk of breast cancer death for Black women with luminal A or ER positive breast cancer as compared to white women. And many of them did not see an association for triple negative or basal A. And these are all observational studies. So often with observational studies, a cohort study, we're concerned that there may be confounders that we're not able to account for, differences in poverty or socioeconomic status or other factors that weren't accounted for. So this has also been examined in clinical trials. So in clinical trials, the women are randomized to different groups to either receive an intervention or not. In general, clinical trial populations tend to be more homogeneous than we would see in a general population. And because of randomization, we're less concerned about the potential for unmeasured confounding. And what they found is that they tend to find associations where they see differences in risk between Black and white women for ER positive breast cancer, but not for ER negative. So Southwest Oncology Group did a study that came out in 2009 where they looked at racial disparities across multiple cancer sites, and they found that only for breast, ovarian, and prostate cancer did they see a persistent racial disparity. And here, when they broke it down by estrogen receptor status, they found that Black women with premenopausal breast cancer are about 70% more likely to die. And and they saw no difference for ER negative. And so there's some consensus building that we can take a couple of things away. Disparities are really not solely being driven by higher prevalence of aggressive tumor subtypes. So I think a lot of attention gets paid to the fact that Black women are more likely to develop these basal-like or ER negative tumors. That's no doubt extremely important, and we do need to find targeted therapies for ER negative breast cancer, and also to understand how to predict risk for ER negative breast cancer better than we can do now. But when we look at the data, really where the action is happening is where we have the most knowledge, tools, treatments, therapies available already. And in these studies, we haven't been able to fully explain the excess mortality. So for the observational studies, of course, it could just be, I don't think that's it alone, but there could be residual confounding. So I will say that in our study, we did not have super measures of socioeconomic status, and there are often small numbers when we get, when you're trying to look at just luminal A tumors and compare Black and white women, there can often be small numbers of deaths in those analyses, so there's more uncertainty around our estimate, but I think the fact that we see it across so many studies for so long suggests that it's a real thing that we need to address. And so what could be going on? There may be differences in treatment adherence and or efficacy of treatments for ER positive breast cancer, and it's possible that there are also other tumor characteristics, within luminal A or within the ER positive subtype that could contribute to some of the differences that we see. So just to jump on, could there be, and is there evidence of racial differences in molecular characteristics of ER positive breast cancer? Before I go to that, I want to say that I'm certainly not a person who's about biological determinism. So there is a lot of evidence that there are important factors, like here I'm showing you data for stage of diagnosis, which affect access to care, and not just access to care, but realized access to care, that contribute to the disparities that we observe. So the data that I'm showing you here is from the American Cancer Society, and it shows the distribution of stage between Black and white women, and you can see here that Black women were less likely to be diagnosed at local stage, more likely to be diagnosed at regional and distant stage as compared to white women. And stage is clearly an important contributor to disparities. But all the analyses that I've showed you have accounted for stage already. And so what we're seeing is something that is beyond this. And that's what I'm trying to get at with some of the data that I'm going to show you. So the question is, are there residual differences in molecular characteristics of tumor that differ by race within the ER positive or luminal A subtype? So there's some data to suggest that within ER positive breast cancer, Black women may have higher risk tumors as compared to white women. And so this data is using Oncotype DX, just to give you some background. That's a 21 gene recurrence score assay. It predicts risk of recurrence for patients with early stage ER positive node negative breast cancer. So these are breast cancers that we expect to do very well in general. And part of the reason that this test exists is really to determine for these women that generally have a very good prognosis, do they really need to have chemotherapy? Is endocrine therapy sufficient, for example? And so what they did is they looked at over 2,000 Black and white women in Atlanta, Georgia, and they compared these gene recurrence scores between Black and white women. And what they found was that there was no difference in the mean score. So on average, the scores between Black and white women were very similar. But what you can do with these scores is you can do what's called risk stratification. So there are cutoffs that you can use to determine what's a high risk for recurrence and what's a lower risk for recurrence. And they did see some differences in terms of where women were classified, such that Black women were more likely to have scores that classified them as high risk. So almost 16% were in that high-risk category for Black women as compared to about 7% for white women. And there were some differences in the low-risk characterization as well. And the author suggests that it's possible that ER-positive tumors in Black women have lower levels of ER expression. So what does that mean? When we talk about a tumor as ER-positive or ER-negative, we act as though it's like a binary thing. You're either yes or no, but it's actually a continuous measure. And the cutoff that we use to determine yes or no right now is at 1%. So anything from having 1% of the tumor cells expressing ER to 100% of the tumor cells expressing ER, we call ER positive. So that's a pretty wide range, and it's totally possible to have variation within that range that could contribute to, for example, responsiveness to medications.
I'm not a scientist, so does that mean this tumor is really not ER positive?
It is. So so basically what a pathologist does is they look at the tumor, they stain it for using an enzyme that can determine whether it expresses ER or not, and then they score it to say, sort of what proportion of these cells are staining positive for ER. And, in our trials, we've seen that even if you go down to just 1% of the cells expressing ER, those tumors still experience a benefit of anti-estrogen therapy, so endocrine therapy, which I'm going to talk a little bit more about. And so that means that when we call a tumor ER positive, it is ER positive, but there's still heterogeneity. There's still some variance within there in terms of just how much ER is that tumor expressing. Does that make sense? Okay. And also, definitely, please feel free to ask questions if there's something I'm saying that is not making sense at any point, okay? All right, so that was, sorry, the formatting on this slide got a little off, but then another study looked at gene expression differences. So they took data from 108 white women, 57 Black women with breast cancer. They looked at a whole bunch of different genes, and they found that these 6 genes here in this table were differentially expressed between tumors of Black and white women. That means that, in tumors of Black women, some of these markers, these genes were expressed more frequently or into higher levels in Black women than they were in white women, or vice versa. And what they found was that the genes here, this is showing you the association of expression of these genes with breast cancer outcomes, so risk of recurrence or breast cancer death. And what they found was that genes that were associated with a poorer prognosis tend to have higher expression in Black women, and genes that were associated with good prognosis had lower expression in luminal A tumors of Black women. And they also saw that 2 of these genes were more highly expressed in even the normal tissue. So this is not tumor tissue, in normal tissue of Black women. And then last thing, using some data from the Cancer Genome Atlas, which is a huge repository of tumors, this study looked at differences in somatic mutations. So those are mutations that just exist in the tumor. They're not in your germline DNA. If you genotyped yourself, you wouldn't find these mutations, for example. And they found that P53 mutations and PIK3A mutations differed between the tumors of Black and white women overall. They were about, P53 mutations were about 90% more common in Black women. PIK3A mutations were about 50% less common in Black women. And as they looked at it by the different types of tumors, they had relatively small numbers, so most of these patterns were not significant, but they did see the same pattern for the hormone receptor positive tumors, suggesting more P53 mutations, less PIK3CA mutations. And that's important because P53 is a tumor suppressor gene, so it's important in sort of regulation and sort of preventing the growth of cancer. So if you have mutations in P53, those are usually considered deleterious and associated with worse outcomes, whereas PIK3CA mutations are associated with better outcomes. So in summary, there are some molecular differences between Black and white women in terms of ER-positive luminal A tumors. Some of these differences could be contributing to the poor prognosis observed for this subtype. I think the mechanisms for how that could operate are not totally clear, but it could be related to treatment efficacy and potentially treatment resistance. And I think it's important to say that I think sometimes when we talk about molecular sort of biological differences between groups, we sort of can couch it in a frame of sort of like in a negative light. And I don't think that is what we should do here. I think these differences, they're real and they should be studied, and we should design medications that could target these differences if they're real. And the reason why we might not have recognized them before is because, the trials that were designing medications and identifying some of these mechanisms behind breast cancer didn't have enough Black women originally, so we didn't see this stuff before. And so I think that's important note to take from this. Okay, and then the last thing I'm going to talk about is adjuvant endocrine therapy, adherence and persistence. Okay, so one of the, endocrine therapy is a super important medication in terms of treating estrogen receptor positive or luminal A breast cancer in everyone. So just give you a little background, tamoxifen, which I'm sure we all have heard of, is one type of endocrine therapy. It's what we call a SERM, a selective estrogen receptor modulator. It inhibits breast cancer growth by blocking the action of estrogen. So ER-positive tumors are estrogen-responsive tumors, and so if we can block the ability of estrogen to feed the tumors, we can prevent them from growing. They're recommended for premenopausal women or postmenopausal women that can't take an aromatase inhibitor. It's a pill that's taken daily, and tamoxifen has been shown to reduce the risk of breast cancer recurrence and death, 40% reduction in recurrence, 30% reduction in mortality, but there are real side effects associated with taking tamoxifen, including risk of, did you have?
So is that 40%, 30% reduction, is that in African American women or overall?
Overall, yeah. This is from the clinical trial. Okay. That one of the first clinical trials that came out that showed the efficacy of tamoxifen. So it's going to be predominantly white. The person that Eric Weiner told you about, middle-aged white woman, college-educated. Yes.
We love her.
Yes.
She's volunteers for clinical trials.
Yes. But it does have side effects. So there's risk of deep vein thrombosis, which is basically a blood clot in your legs, or a pulmonary emboli, which is a blood clot in your lungs. Uterine cancer risk is higher with use of tamoxifen, though the absolute risk is still very small, so like 4% for women who take tamoxifen compared to 1% for women who didn't. But the real side effects that impact, I think, adherence are things like hot flashes, vaginal discharge, sexual dysfunction, menstrual irregularities. If you're taking tamoxifen and you're a premenopausal woman, which is the group that it's primarily indicated for, your periods may stop, you could still be in childbearing age, you can't be pregnant and take tamoxifen. So there are real implications for taking tamoxifen on lifestyle. Aromatase inhibitors, these are medications that are indicated for postmenopausal women, and they suppress estrogen levels in a different way. So when you're postmenopausal, your ovaries are no longer making sex hormones, so your ovaries aren't producing estrogen, for example, anymore. And so the way that your body gets estrogen is by converting androgens, so things like testosterone, into estrogen, and the enzyme that does that is something called aromatase, okay? And so aromatase inhibitors work by blocking the action of aromatase and preventing your body from turning testosterone into estrogen. And there also have been clear evidence that it reduces breast cancer recurrence and mortality. The data here showing you like a 30% reduction in recurrence and a 15% lower breast cancer mortality is based on comparing it to tamoxifen. So AIs are superior to tamoxifen in postmenopausal women. But again, there are real side effects associated with it. Predominantly, it's possible to develop joint stiffness, pain, bone pain, and for some women that can be very severe. I mean, it can be severe, debilitating pain, but it's in a smaller percentage of women. It's also associated with sexual dysfunction, including like vaginal dryness, osteoporosis, fractures, and high cholesterol can also result from it. So for guidelines, if a woman is not having any other adjuvant therapy, so she's not going to have chemo or radiation, then endocrine therapy is usually initiated within 4 to 6 weeks after having surgery. If she is going to receive adjuvant chemo or radiation, then endocrine therapy is going to be initiated after chemo and radiation are completed, or it's possible to do it concurrently. There really isn't great evidence to suggest that there's a difference between if starting after or starting during chemo and radiation. Important thing to note, the recommended minimum treatment duration is 5 years. So this is a medication that you have to take for a long time. And in fact, recent data suggests that there's continued benefit for up to 10 years. Okay, so this is a long-term medication. And so inherently there are some challenges with it, given some of what I've just presented to you. So non-initiation, this means that a woman never starts endocrine therapy. She has a ER-positive tumor but doesn't start ET. Data suggests that between 12 and 17% of women never initiate therapy. For non-adherence, that means start endocrine therapy but don't take it as prescribed. So you don't take it every day as prescribed. For tamoxifen, between 16 and 28% of women don't fully adhere. For AIs, it's between 20 to 31%. And for non-persistence, that means you start endocrine therapy, but you don't take it for the recommended duration. So you don't hit that 5-year mark or 10-year mark, depending upon your personal risk. And about a third of women discontinue tamoxifen before hitting that 5-year mark, and between 19 and 25% discontinue AIs. So these are real challenges that I think as a health system and as advocates we really have to understand, what we can do to help improve medication persistence, adherence, and initiation.
Do we know the numbers of that? Those numbers are minorities who, are not adherent, non-persistent, and never start?
Next slide. So there's a fair amount of evidence that suggests that adherence, persistence, initiation is a problem for everybody, and then it may be particularly a problem for minority populations and for low socioeconomic status. So I'm just showing you a couple of studies, but there's actually a huge body of literature on it. So in this Detroit and Los Angeles study, they actually found that Black women were more likely to initiate therapy. They saw this for both Black and Hispanic women. We're over 3 times more likely to initiate endocrine therapy. But as they followed up women over time, they found that Black women were about 28% less likely to persist 4 years later. So are you still taking the medication was problematic. And then this graph I'm showing you here is data from a study at Columbia, and they looked at the interaction between net worth, so sort of what's your wealth, and race in relationship to endocrine therapy adherence. And And what they found, sorry, by pointer. What they found was that there was an interaction between race and net worth. So they didn't see any racial differences for high net worth patients. And there was a little bit of a difference for medium net worth, but for low, women who had low wealth. So where do we get wealth? We get it from, you could have big money in your bank account. Often it's owning a home is a important source of wealth for populations. That's where they saw the real disparity. Okay, so there was a really great review that looked at barriers and facilitators for endocrine therapy. And so they found that side effects, so fear of side effects was an important factor in terms of non-initiation, the women who never started taking endocrine therapy. Experiencing side effects was an important factor in terms of not continuing to take the medication or not taking the medication daily, which makes sense. Again, some of these side effects that I showed you could very much impact your quality of life. Cost was not found to be a real factor in initiation, but did contribute to early discontinuance. So, having to pay for the medication over and over again over many years cumulatively was associated with early discontinuance. There's also some evidence of provider communication problems and confusion from women in terms of what was actually being told to them by their doctor. So, I'm going to come back to this provider, having your oncologist or your doctor really tell you very clearly what the medication is, how you're supposed to take it, why it's important to take it, is essential, I think. And so, in some of these studies where they actually interviewed women, they found that, patients said things like, the doctor told them to stop taking the medication, or they suggested that the doctor said that they didn't need to take it, or that the doctor left the decision up to them, which again were all things that were associated with either not starting or stopping early. And I think just of these unclear benefits, this idea that women weren't sure whether taking endocrine therapy was actually helping them. They couldn't see or feel the benefit of taking a medication, but they might actually be seeing or feeling negative side effects. So that balance, I think, is important. And then what were facilitators? This is actually written more as a barrier, but lack of provider communication, I think, as I just mentioned, was essential. And it was the most frequently cited issue across all groups. So the provider, I think, is essential in trying to fix this important problem. But there were about 1/5 of women who didn't start who did so even though their provider had recommended it. So provider recommendation is not a panacea, but I think that it is an important point. And then other interventions like navigation interventions to help women continue to make their to take their medication. Reminder calls, reminder letters were important just to reinforce. Again, it's something you have to take for a very long time, just to reinforce its importance, as well as educational materials. So, in summary, I think the observed consistent poor survival of Black women with ER-positive breast cancer, I've gone through two factors. One is related to maybe there are some differences in tumors that affect either the efficacy of a treatment, the likelihood that a treatment will develop resistance, and we need to really determine the clinical implications of these differences, as well as we need interventions to really decrease disparities in adherence to endocrine therapy. I think we need interventions to increase use of endocrine therapy overall, and then really to target disparities as well. I want to acknowledge the people that contributed to some of the work that I presented, including Ann Partridge, who's at Dana-Farber, and Rula Tamimi at Brigham. And I did want to say that I'm a part of the Boston Breast Cancer Equity Coalition, where we are trying to reduce disparities in breast cancer mortality right here in Boston. There are a number of people in the room that are a part of the coalition. Could we get a couple hands? Yeah. So definitely, please feel free to reach out to all of us. And thank you. This is my email. Oh, it's in yellow. You can't really see it. But here's my email. Here's my Twitter handle, ewarner_12. I'm very active on Twitter. Please reach out to me. Thanks.